Management of dental crowding. For the management of dental crowding, we have to classify the crowding into three main categories: the mild, moderate, and severe crowding. As a general rule, for alignment of crowded teeth, we need to create a space for the crowded teeth within the arch. The space created within the arch in general either by extraction or expansion of the arch. First of all, the mild crowding when the arch length discrepancy is less than 4 mm. The arch length discrepancy is measured by the space analysis that discussed before. In the mild crowding cases, the extraction is rarely indicated, and only if there is a severe incisor protrusion. In addition to the mild crowding, in this case, we need for the extraction to correct the severe incisor protrusion with the mild crowding. Without the presence of the severe incisor extrusion and protrusion and only mild crowding, the choice of extraction will cause an excess space that remain after the alignment of crowded teeth. And in this case, we need for over retraction of the anterior teeth and will be anesthetic for the treatment. So, in the mild crowding, we need for either molar distalization or proximal stripping or proclination of anterior teeth or derotation of posterior teeth or uprightening of tilted teeth or arch expansion instead of the extraction of the tooth. For the more general rule, the molar distalization give good result for creation of space when the maxillary or the mandibular second molar is still unerupted. Two methods for distalization of the molar, either the headgear or lip bumper. The headgear mostly used for distalization of maxillary first molar or maxillary molars by adding or by applying 40 grams to achieve the molar distalization, and the headgear should be worn 12 to 14 hours per day and provide approximately 2 to 2.5 millimeter of space per each quadrant, while the lip bumper is mostly used for the distalization of mandibular molars, which cause a brightening and distal molar of the lower distal movement of the lower molar, forward movement of lower incisor, and some transverse arch expansion. In the headgear and lip bumpers, the success of treatment depend on the patient compliance or patient cooperation. So when the headgear and lip bumper indicated for the patient with highly cooperative. The second method of creation of space for crowding teeth is the proximal stripping. The proximal stripping has many names, either proximal stripping, interproximal enamel reduction, slenderization of the teeth, disking of the teeth, proximal slicing, all the same name for the proximal stripping. In the proximal stripping, we make a selective reduction in the mesiodistal width of certain teeth, and mostly the mandibular teeth are used in the proximal stripping. In the proximal stripping, we create about 1 millimeter of stripping from the mesial and distal surface of the posterior teeth, and we can reduction or reduce 0.75 millimeter from the mesial and distal surface at the contact point of the anterior teeth to create a space of about 2.35 millimeter to correction the case. There is advantage of the proximal stripping. One of the advantage of the proximal stripping to avoid extraction in the case, and on the second, when there is a tooth material excess or large size of the mesiodistal width of the teeth can be reduced to produce broad contact to give additional stability to the result. The reduction of the mesiodistal width either by a metal strip as here, or perforated diamond disc, or perforated abrasive disc. The disadvantage of this procedure is the sensitivity of the tooth after the stripping. In addition, the roughing surface, the mesiodistal surface of the stripped tooth increases the caries susceptibility. So after the interproximal stripping, we need for highly oral hygiene maintenance, in addition to adding a fluoride to the area. In addition, the food lodgement may present as in this space that created dislodged in this spaces after reduction of the mesiodistal width or proximal stripping. The proclination of retroclined anterior teeth or proclination of the anterior teeth is regarded as a method of space creating in the crowded teeth. So it's used when the anterior teeth are retroclined, as in this case, but without change or affect the facial profile, and the cases mostly have a nasolabial angle are out use. The other method is derotation of the posterior teeth, and the derotation of the posterior teeth, as here illustrated, can provide 1 to 2 millimeter of the space. So here, when the molar is in correct position, the mesiodistal width is about 10 millimeter, but when it is rotated, the space that occupied in the arch is 11 to 12 millimeter. That means the rotated molar occupy more space in the arch than the corrected molar. A brightening of the tip teeth, as in this case of the tilted molar, here the tilted molar take more space or occupy more space in the arch than the rotated molar. So the brightening of the molar can create a space for the alignment of the anterior teeth either by a brightening spring, this is the brightening spring, or a coil spring. The moderate crowding is when the arch length discrepancy is more than 4 millimeter. That means 5 to 9 millimeter. In the moderate crowding, we either use non-extraction method, which are the distalization of the molar, derotation of the molar, a brightening of the molar, a proclination of the anterior teeth, interproximal stripping, as mentioned before, or use extraction according to the space analysis. When the arch length discrepancy is 5 to 6 millimeter, we prefer the non-extraction method. When more than 6 millimeter to 6, 7, 8, 9 millimeter, we make a space analysis and check the profile of the patient, check the stability of the result, and we prefer the extraction of tooth. In the moderate crowding, we can use, as in this case, expansion of the whole arch. Orthodontic expansion, as in this case, this is constricted maxilla with the crowding of the anterior teeth. The expansion is very preferable, and here the expansion result in the correction of the crowding teeth. The expansion of the arch, either passive expansion or orthopedic expansion. In the passive expansion, the passivity of expansion due to the effect of the tongue on the upper arch and increase the pressure of the tongue more than the pressure of cheek on the dental arch by eliminating the effect of the cheek on the dental arch by using of the buccal screen and lip screen, which is called the Frankel orthopedic appliance. And by the pressure of the tongue, the arch will expand laterally and anteriorly and eliminate and produce a space for alignment of crowding. In case of orthopedic expansion, we need a true expansion of the palate or the maxillary arch by using, for example, rapid maxillary expander. Here, the rapid maxillary expander, or called the Hyrex, cause opening the mid-palatal suture and expand the maxilla. And when the maxilla is expanded, there is a space created for the alignment of the anterior teeth. In the severe crowding cases, the arch length discrepancy of more than 10 millimeter, we prefer the extraction of certain teeth that close to the area of extraction for the alignment of severe cases.